Our next paper is Patient-reported outcomes after single-incision laparoscopic cholecystectomy versus traditional laparoscopic cholecystectomy, a randomized prospective trial that will be presented. You don't look like Matthew.
Kimberly Brown.
By
Kimberly Kimberly Brown and the group from the Department of Surgery, University of Missouri in Kansas City.
Thank you very much. I'm grateful to the program committee at SAGES for the privilege of the podium today. This study was performed with some support from a research grant from Covidian. Laparoscopic cholecystectomy has been considered the gold standard for treatment of benign gallbladder disease since the NIH Consensus Conference in 1992. After initial dissemination of the technique, an increase in complications, specifically common bile duct injury, illustrated a unique skill set and learning curve associated with this new approach. However, more recent data indicate that beyond the learning curve, the laparoscopic cholecystectomy is overall a very safe operation, with more recent studies showing common bile duct injury rates at or below 0.3%. Additionally, in recent years, laparoscopic cholecystectomy in elective cases is performed as outpatient surgery, frequently with same-day discharge. So these observations suggest that the gold standard operation is going to be hard to demonstrate an improvement upon. Single-incision laparoscopic cholecystectomy is a newer approach, striving to make this procedure even less invasive. There have been a recent increasing number of case control series, and now randomized trials reporting on feasibility, safety, and procedural outcomes such as operative duration. Proponents of the technique state that patient benefits are in improved cosmesis and reduced pain, which may result in faster return to work or other normal activities. However, there remains a paucity of data with which to inform patients considering this procedure about what benefits they may reasonably expect when selecting a single incision approach versus a traditional laparoscopic cholecystectomy. Also, these procedures are performed with a variety of techniques, sometimes using standard laparoscopic equipment or sometimes incorporating specialized access devices or instruments, and it's unclear what the overall effect on healthcare costs is going to be from incorporation of a single incision approach. Thus, the purpose of the current study is to identify patient-centered outcomes that may differ between a single incision and a traditional laparoscopic cholecystectomy. Our primary outcome was recovery time, which we measured by a GI quality of life index score. Our secondary outcomes included pain levels, narcotic use, satisfaction with wound appearance, procedural outcomes, and cost. The GI quality of life index is a GI-specific health-related quality of life questionnaire. It's administered as 36 questions, including physical function, symptoms, mental, emotional, and social aspects. Each answer is on a 1 to 4 or 1 to 5 scale, and the worst health outcome would be given as 0 points. The best would be 4 points, such that the total score would range from 0 with the worst health to 144 in best health. It's been extensively validated, including multiple cohorts of pre- and post-operative cholecystectomy, both laparoscopic and open, and we felt that given the use in this laparoscopic cholecystectomy population, this may be the most applicable tool with which to gauge recovery and quality of life in this population. We designed our study as a prospective, randomized, single-blinded trial. We identified patients from outpatient consultations with our participating surgeons. Consenting patients were randomized in the operating room after the induction of anesthesia and underwent either a 4-port laparoscopic cholecystectomy with a 5-millimeter port in the epigastric position or a single incision laparoscopic cholecystectomy. And our 3 surgeons performed this technique with a single incision at the umbilicus, followed by 3 fascial incisions through which a 5-millimeter bariatric port scope was used and 2 5-millimeter low-profile trocars through which instruments were placed. At the end of surgery, patients had uniform dressings placed on all of the sites through which a 4-port cholecystectomy would be performed. Those were maintained for 48 hours. We collected baseline demographics. We performed a GI quality of life index survey preoperatively and then at 2 and 4 weeks postoperatively. We recorded operative data such as duration. We recorded pain scores in the recovery room and throughout the first 48 hours in a patient log. We recorded narcotic use in the OR, in the recovery room or PACU, and for the first 48 hours. And we abstracted both the procedure-specific costs and the entire encounter costs from our hospital billing data. This flow sheet summarizes the study enrollment. Initially, 103 patients were approached and consented for inclusion in the study. 24 patients were subsequently excluded. 9 ended up not having any surgery. 4 withdrew their consent because they wanted a single incision approach. 6 were determined to be ineligible by the surgeon through the course of workup. That left 84 patients to be randomized. 5 were excluded because they had additional procedures performed at the time of their cholecystectomy, which was set out in our methods as an exclusion criteria. And that left 40 patients in the single incision group and 39 patients in the traditional laparoscopic group. Due to incomplete follow-up in some of our patients, you can see here the patients available for evaluation at our different time points. The baseline characteristics in our populations are shown here. There's no difference in the single incision and the traditional laparoscopic cholecystectomy group in age, in gender. The overwhelming majority of our patients were Caucasian and had private insurance. And there's no difference in which surgeon saw and operated on patients in each group. There's no difference in prior abdominal surgery. Our 2 diagnoses, there's no difference in the 2 groups. And again, these were elective patients, so there's no acute cholecystitis or biliary pancreatitis. The BMI in our population was around 30 in each group. And there's no difference in smoking status or number of comorbidities. Our GI quality of life index study preoperatively was the same, and it was also consistent with other studies in the literature of preoperative cholecystectomy patients. Our operative outcomes are summarized here. Our single incision procedure took on average about 10 minutes longer than the traditional group. In recovery room, the single incision patients required significantly more narcotic than the traditional lap chole patients, despite having equivalent doses of narcotic intraoperatively. We found no difference in pain level at PACU discharge, no difference in PACU length of stay or hospital length of stay, pain scores in the first 48 hours, or the number of narcotic pills taken in that time. Our patients reported an average duration from their surgery to returning to work or other normal activities of 8.2 and 8.6 days in each group. This graph depicts the GI quality of life index scores at the preoperative time point, 2 weeks and 4 weeks postoperatively for the single incision group in black and the traditional lap chole group in white. And you can see that each score increases with time as would be expected, and there was no difference between the 2 groups. Patients were asked the question, how satisfied are you with the appearance of the wound? And we're able to give an answer with these anchoring texts shown here. The y-axis is % of respondents. And at the 2-week time point, you can see that there is a significantly overall improvement in satisfaction with the wound's appearance in the single incision group. We asked the same question again at 4 weeks, and again, overall, there was an increase in satisfaction and wound appearance in the single incision group, although the statistical significance was lost. This graph depicts the cost data in US dollars between the single incision and traditional laparoscopic cholecystectomy groups, as well as the cost for the entire hospital encounter, and those were similar. A few considerations in interpreting our data. One would be generalizability. Our study population was overall very socioeconomically privileged. These were all elective cases and a high proportion of biliary dyskinesia, so they would be expected to do well. Our study setting was a community teaching hospital which functioned as a private practice environment, and as such it may be more generalizable to the average surgical practice across America. Despite structuring this as a prospective control trial, there is an inescapable bias. There were many patients who presented who would have otherwise been eligible for this study who wanted the single incision approach and were not included. Additionally, our surgeons did have criteria for considering whether a patient would be eligible for a single incision surgery and therefore for the study. And anecdotally, patients with larger BMIs and with prior open abdominal incisions were less likely to be offered study enrollment. And of course, our sample size is small, which illustrates the challenge of accruing to these types of studies. So in summary, the single incision approach for cholecystectomy is a slightly longer operation, but that does not incur additional healthcare costs. We found more narcotic use in the recovery room, which may illustrate the fact that it is the umbilical incision that's the most painful. And of note, we did not use any particular adjuncts such as intraperitoneal analgesic infiltration. Recovery time and trajectory were equivalent in these two procedures. And we did find that there was an early post-operative improvement in satisfaction with the wound. And thank you.
So as you might imagine, there are a number of tweets coming in fast and furiously on this topic. I'd encourage all of you to tweet early, since some people have fast servers and some people don't. Was the critical view of safety obtained in all cases?
The dissection was, was conducted with a critical view of safety in both the single incision and the traditional group.
Dr. Brunt.
Michael Brunt, St. Louis. Congratulations on a very nicely done study and for including the quality of life measures in your outcomes. The questions that I have are, how did you keep the cost down in the single incision group? Most of us who've done this have used some other disposable instrumentation, maybe even a 5mm clipper plier, which can add significantly to the cost of the procedure. So I'm curious how you did that, number one. Number two, did you do cholangiography either selectively or routinely in either of the two groups? And number three, we're on the other side of the state of Missouri, but we just really haven't seen much in the way of patient demand for the single incision approach. So I was wondering if you can comment on that. Are you having patients that are asking for this procedure?
Absolutely. In terms of the cost, our surgeons, when they started adopting this approach, did use some of the specialized access devices, but for the most part, they settled down on a technique that really used all the traditional, usual laparoscopic devices. They did use a bariatric camera to give some additional length and to keep the cord out of the way of the other instruments. The rest of the operation is really conducted the same. In terms of cholangiography, I think because of this population, there was a very low incidence of cholangiography, and that was, again, at the start of the study, excluded as a separate procedure. And that would certainly change the results if you were including patients with acute cholecystitis or gallstone pancreatitis who may be more likely to undergo a cholangiography. I was actually surprised at the sudden explosion of patient demand in our center, and I think that the referring doctors, in my opinion, largely drove that. We did a study of patient perception, so asking patients when they came in to be seen for possible gallbladder problems, whether they had heard it, and over 40% of the patients walking in the door already knew about single incision surgery, and this was already a couple years ago. So I'm not entirely sure why that became so popular so fast in Kansas City, but my anecdotal observation is that the referring doctors heard about it and thought it was impressive.
So we have a couple of key questions. Jerry, you had a question.
Yeah, my question is a two-part one. One is, on what outcome data did you actually power your data analysis? Because your numbers were relatively small in each group. So I would assume that prior to doing a beautiful study like this that takes great effort, you did a power analysis. My second question is, why did you use GI quality of life outcome as one of your measures? Because one wouldn't think that from the perspective of GI quality of life that whether you used 4 incisions or 1 incision, that specific outcome measure would be something likely to vary.
So we powered the study for a change in the GI quality of life index, and we had hoped to accrue between 100 and 150 patients, ideally 150 patients. And throughout the course of the study, the ability to recruit patients onto it became more and more difficult. And so this was intended to be an interim analysis, but my suspicion is this will be as many as we're gonna get on the study. The patients have opinions coming in that make it pretty hard to accrue. Thus the small numbers. Now, the use of the GI quality of life index as a health-related quality of life, it has been shown to improve at multiple time points after cholecystectomy, and if there was going to be a way of detecting a difference, since it does incorporate pain, as one of its subscales, it seemed that would be, of the methods out there, the most likely one to discriminate.
So, Dr. Brown, there's two groups of questions that are showing up here on Twitter. One is concern about hernia. Did you observe hernia, and are you going to continue to follow your patients long-term for hernia? Because, as you know, all the benefits disappear if you have to reoperate on patients. And then the second question is a lot of comments on how nice the paper is, but the differences are inconclusive. What are you going to do when you go out into practice?
Absolutely. So in our prior study, which was a retrospective review of single incision versus traditional lap chole in our institution, we did have a slight 2% increase or incidence of hernia in our single incision population, and that's consistent with the other studies that have followed patients out for a year or so afterwards. And I absolutely agree that that is one very important unanswered question. Patients would not want the surgery if they knew that they had an increased risk of having to have more surgeries down the line.
And what are you going to do in practice?
I think that the traditional four-port laparoscopic cholecystectomy is a fantastic operation. I also am involved in training residents, and what I noticed in this study and others is that junior level residents are not doing these single incision lap choles, and that's how they learn laparoscopic surgery. So they're taking on more complex cases is being delayed because they're missing the opportunity to learn this skill at a younger level. I think that's a significant issue for doing this in a training setting.
Hi, Jonathan Carter, San Francisco. Wonderful study. My question was, one of the purported benefits of SILS is cosmetic appearance. And I'm wondering if you have any plans to survey your patients or maybe otherwise assess cosmetic appearance long-term, 6 months, 12 months out.
That is certainly something we could follow this study for. It has been done in other places, and in fact, even asking patients who had surgery how many incisions they have. Many of them cannot even tell you accurately how many incisions they had. So I think that long-term, we may not find too much of a difference either.
So let's give Dr. Brown a hand for a pretty balanced presentation on a tough topic.